I am actually very excited to explore a topic that touches all of us, whether professionally, personally, or through the communities that we live and serve. Cancer is changing, and so must our strategies to detect, prevent, and respond to it. So let's start with a simple but powerful question. If you were diagnosed with cancer right now, what comes to mind? Fear, uncertainty, death, resilience, maybe hope. Cancer is not just a disease, it's an experience. It affects our minds, bodies, families, and systems. It even affects our finances. This emotional, medical, and societal journey is part of why we must rethink our approach. But here's the thing, cancer's story is changing, and it will continue to change. And to understand why, you need to zoom out and actually look at the bigger picture, what we call the epidemiological transition. Now, as societies actually evolve and modernize, so too do their disease patterns. This is known as the epidemiological transition. So decades ago, and still characteristic of many regions still in the early stages of the transition, like Africa and certain parts of Asia, there was high mortality, and this was driven predominantly by famine, pestilence, malnutrition, parasitic diseases, and infectious diseases like tuberculosis and cholera. But for countries in the later stages of the transition, particularly the high-income countries like Japan, USA, UK, Europe, and the Caribbean now, through significant advances in public health like widespread vaccination, improved sanitation hygiene, we have actually extended our lifespan. But this progress comes with a price. It has led to a notable shift in the epidemiological patterns of disease, where now our primary causes of death are no longer infectious diseases, but man-made chronic condition, most notably cancer. And this change reflects more than just biology. It reflects how we live, how we age, and how we interact with our environment. So what's driving this era of chronic diseases? Dr. Fraser touched on some points. An aging population, we are living longer. Great, that is great news. But longer life also means more time for genetic mutations and more exposure to risk. We're also seeing a lifestyle shift. Our dietary patterns have taken a more westernized edge. More processed food, less exercise, more pollution, more stress, which now equals a greater cancer risk, even in places where it was once rare. And while these trends raise concern, they also bring a key opportunity. Unlike many diseases, up to almost half of cancers are preventable. That's not just helpful, that is powerful. Smart policies like sugar taxes, preventative strategies like healthy workplace policies, and early detection can actually change the game. But let's take a closer look at some invisible drivers that we tend to overlook or are not cognizant of. And we're talking about globalization and social inequality. Right? But before we get to that, we're going to talk about the rising global cancer burden. Dr. Fraser actually spoke about this. The black lines indicate the global trend. The yellow lines indicate the Caribbean trend. And right now we're talking about the incidence. The incidence just means the new cancer cases that are diagnosed yearly. And we can see a steady increase for both men and women. But I want you to notice the sex disparity, right? Who is being diagnosed at higher rates when you look at this graph? The males, very good. Now, when we look at the Caribbean, we see that it's following the global trend as well. Now, the Caribbean only houses maybe between 1 to 1.5 of all global cases. But just like the global patterns, we're seeing that steady increase. Cancer deaths are also increasing. And again, notice the sex disparity. Who is dying at higher rates? The men. If the men are dying, we're not going to have anybody to marry. The men are dying. Now let's look at the Caribbean context. Again, we're seeing that steady increase in both incidence and mortality. Now, this is particularly concerning because if we're having higher mortality rates in men, but the incidence is decreasing, it means that there's a gap somewhere, right? There's either a gap in the early detection of their cases of the disease, in treatment or access, or even survival outcomes. Or it could actually mean that there is something significantly different in their behavior versus females' behaviors. Now, Dr. Fraser spoke about this, so we're not really going to touch on this, but for instance, again, we see that prostate cancer, colorectal, lungs are usually the top 3 cancers for men, females, breast, colorectal, and is between lung and cervical cancer for females. For mortality, again, males, what's affecting males, lung, prostate, colorectal. And for females, we see lung, colorectal, and breast that are killing them. Now, numbers alone don't tell the full story. To understand cancer cases and rates, we actually need to look at the risk factors people face and how they perceive them. So we're going to do a very quick poll. I love polls. I'm an epidemiologist. So, myth or fact? Up to 10% of cancer cases are related to genetic mutation, whereas 27% of cancer deaths are from tobacco and alcohol use. Myth or fact? Fact. Myth? That's a fact. Healthy diet and regular exercise reduce cancer risk. That's a fact. Good. If you feel fine, you don't need screening. Myth. I thought men would say a fact. Breast cancer only affects middle-aged women. Myth. Good. Cell phones cause cancer. That's a fact. The jury is still out on that. We're currently still doing research into this. That's a fact. Okay. Children who are obese will naturally outgrow their weight issues. That, very good. That is a myth. So these myths can actually delay diagnosis and cost lives. So let's shift right now to what really drives cancer risk and what we can do about it. Again, Dr. Fraser touched on this. So this chart is a compilation of what studies have shown. So these are the key risk factors that drive disease, cancer risk. Disease. Tobacco use, overweight, poor diet, inactivity. These are not just lifestyle choices. These are actually factors that increase your risk of getting cancer, and they are completely modifiable. In other words, the prevention is in your hands. Now, I spoke before about invisible underlying context, or driver, globalization and inequality. Then when we talk about globalization, we're talking about the unprecedented interconnectedness between countries. We talk about economically, culturally, socially, and this brings many benefits, right? But it also has significant, often overlooked negative implications for a country's health, particularly cancer, right? For example, are we eating differently than our grandparents? Yes, and our nutritionists over here whispering that from the rooftops. Right? Global trade has increased access to ultra-processed, highly refined, high sugar, high fat, high salt, obesogenic foods. And this has raised the obesity-related cancer risk. Take China, for instance. They have actually seen a cultural shift. In the past, their diets were rich in vegetables, grains, and teas. Low red meat, low dairy. But over the past decades with globalization and their economic growth, it actually brought the Western lifestyle, which we are currently experiencing, into their country. High fat, high sugar, low fiber diets. And as a result, what they're seeing is now a surge in their colorectal and breast cancer rates. What about migration? That can bring cancer risk. We've seen it with COVID. They don't respect borders. Diseases don't respect borders. So where people go, so too do health risks. So increased travel and migration can bring cancer-causing viruses and bacteria like HPV, hepatitis B or C to new populations, actually changing our disease profile and therefore our service needs. What about urban development? Right? We love the convenience, the new roads, the big houses, right? The cars. But that brings more traffic, more pollution, less space to actually exercise, all of which affect cancer risk. So globalization changes how we live, but not everyone can adapt. And cancer is not just a risk that matter, but whether you have the resources to avoid or survive them. So let me introduce you to two women. Same age, different diagnosis. Same age, same diagnosis. So meet Althea. She's a government worker. She works from 8:30 to 4:30. She's a mother of two, a family woman. She goes to church. She currently felt a lump. But unfortunately, her diagnosis was delayed because she could not find the time to go to the doctor. She was just simply too busy. Right? She has public health insurance, but it doesn't cover everything. So she has to deal with the out-of-pocket costs. So she delayed going into her doctor. So 3 weeks later, she finally got her diagnosis, stage 3 cancer. Right? Now meet Rachel, marketing manager. She works at a trust fund. She's also 39 years old. She has both public and private insurance. She has flexible working hours in her managerial role. She finds a lump. She immediately goes to her private care physician and is immediately referred for imaging. They find she's stage 1 breast cancer. She was able to catch it early. And her cancer journey was totally different from the first person's because she was able to actually afford the care and she has access to the care that she needed. Now, this brings us to our prevention imperative. Now, most cancers, well, up to half cancers are actually preventable. And prevention isn't just cheaper, it saves lives earlier. It's actually our best return on our investment. Now, how do we put that into action? Through our cancer prevention and control. Cancer prevention and control is actually a cycle. So we talk about education, policy, screening, care. Education, policy, screening, care. Each reinforces and builds upon the other. As studies have shown, if you only enact them in isolation, they fail. They have negligible impact on cancer rates. And if you break one link, the entire system weakens. And this is why there needs to be a coordinated and collaborative effort between Ministry of Health, our NGOs, our private and medical fraternities. And there must be a strong framework guiding action. And our framework must consist of policy, healthcare systems, community programs, individual action. The policy needs to come from the national level. The national plans set the tone. Then the infrastructure enables actions. And then we have the community programs, which we're supposed to be doing. It increases awareness, it builds attitude, self-confidence, teaches skills to actually facilitate the individual behavioral change. And how do we know if that system will work? Through epidemiology. Epidemiology is our GPS. It maps the road ahead, showing trends, risk factors, and what's working. Without it, we're flying by the seat of our pants. But GPS is only as good as the data that we give it. And this is where the cancer registries come into play. Now, the Minister of Health spoke about the regional call for action. And it's very true. There has been a global and regional call for action for all countries to establish high-quality, population-based registries, especially in the Caribbean. At present, less than 10 Caribbean countries have cancer registries, BVI included, with only one meeting international quality standards. And I would like the BVI to be the second. Registries track who is getting cancer, when and how. And they're essential for knowing where to act and how well our efforts are working. And there are two main types of registry: population and hospital-based. Now, population-based registry, it gives us a holistic 360-degree view of what is happening. Think big picture trends. Hospital registries, on the other hand, only offer clinical insight. They're supposed to feed into the population registry. And this data is not just theoretical, it needs to be used to drive real decisions. We collect a lot of data here in the BVI, but we don't use it as we should. Now, registries guide everything from research, resource allocation, health planning, and cost savings. This is how we work smarter and not harder. Now, let's look at a real-world success story. Now, the minister said we are actually working towards cervical cancer elimination. Australia is way ahead of the game. Now, in 1991, Australia actually launched its national cervical screening program, which initially involved Pap tests. The national and state registries were developed in tandem, and they were critical in collecting comprehensive data on screening participation, test results, incidence, and mortality, and tracking the impact of the program over time. Between 1991 and 2002, the registry data actually showed a 50% reduction in cervical cancer rates. Using both the screening and cancer registry data, Australia then identified high-risk populations that were being underserved, such as the socio-economically disadvantaged, and developed tailored strategies like the expansion of these self-collection options to improve equity and access. More than just a data collection, the registry actually acted as a patient safety net, ensuring timely interventions and follow-ups. So thanks to their coordinated screening, the development of the cancer registries, the vaccination programs, Australia is actually on track to eliminate cervical cancer as a public health threat in 2035. This is the power of prevention and data. Now, where are we now? BVI's registry implementation status. So our legislation has been developed in 2024. We have our cancer registry platform installed and ready to go. Our procedural manual is actually in the final stages of being vetted by our international agencies. And we are actually working with our stakeholders like Health Services Authority, NHI, our various private care physicians to collect the data. And we hope to launch at the end of 2025, early 2006. Now, once we get that registry up and running, this is how we are then going to work on policy development. So we want to strengthen our national care plans. Then we're going to implement our programs. Dr. Fraser spoke about this. And then we're going to conduct research into patient care. Because really it's not just about collecting information, it's about changing lives. And one of the studies that is currently ongoing in the BVI is to actually understand the lived experiences of cancer patients. And you're going to be hearing a lot more about that in the next coming weeks. Now let's end where we began, with hope. We actually need the numbers sharp and clear. We actually need to share knowledge and raise our voices. We need our systems rebuilt, strong and fair. We actually need to find the strength to shift the tide, to guard the lives we're meant to guide. So today, through all that we have learned, let us actually protect our own from this point on. So thank you for listening, participating, and caring. I'm open to any questions right now.
We know that where you choose to bank matters, and it is your vote on what your funds do in strengthening our community. As your official Bank of Paradise, we invest and support the lifeblood of our economy by helping in the realization of personal goals for homeownership, education, and entrepreneurial visions, which support small businesses. We make it our place to connect with persons and worthy causes, and we have been doing so for more than 30 years. Where your money goes and what your dollars empower are your choice. And we thank you for choosing us, a bank that gives where it matters the most, for you, for our community and a happier tomorrow. The National Bank of the Virgin Islands.